I'd like to welcome everybody to today's webinar, Improving Ohio's Health, Final Perspective. This is Scott Mash, and I'll be joined by Ms. Kathy Costello and Ms. Kathy Rich. If you do have a question at any time, you can enter that question in the questions feature of GoToWebinar. If you just click on the orange arrow there on your control panel, you'll see that the GoToWebinar app will expand. You type in your question. At the end, we will take time to answer each and every question we receive. Also, the handout, which is today's slide deck, is available in the handouts feature of GoToWebinar. I want to review the agenda real quick. First, we're going to start out by talking about the grant basics, where we started. We're going to run through the data that we've collected throughout the life of this grant, this opportunity, working with all of the great participants here in Ohio. We're going to talk about the tools that within the CliniSync HIE that you can use to manage your patients with prediabetes, diabetes, and hypertension. Talk about the referral tool, some work some folks have done with building screening tools in their EHRs, and we'll also take a quick look or talk about the community health record. We also want to focus on the partnerships that develop through the life of the grant with the local health departments, YMCAs, and some of the other organizations. First, I'd like to turn it over to Ms. Kathy Costello.
Thanks, Scott, and welcome all. We're so happy you can join us for our webinar today. This is the last webinar that we will be holding on the Ohio Diabetes and Hypertension Project. Ohio participated in the CDC-funded four-year project to support a population-wide approach to the prevention of obesity, diabetes, heart disease, and stroke. Ohio was one of only 17 states who received funding for this comprehensive approach to treating these chronic conditions. Although there were numerous community activities supported through this grant, our portion of the grant work included gathering data on diabetes and hypertension from all 88 counties, both as inpatient statistics and as ambulatory quality metrics. We also supported optimizing EHR systems to better track and report on these quality metrics, as well as providing education on prediabetes and hypertension. Many of you on this call were partners in compiling this data, and hopefully you will be very pleased with these results. Our thanks go to all of our partners in this project. First and foremost, the Ohio Department of Health, the Ohio Hospital Association, the Ohio Academy of Family Physicians, the Ohio Association of Community Health Centers, the 6 individual county health departments that we worked with, the regional health collaboratives, and all of your organizations. I'll turn it over in just a minute to go through in more depth the data, but I just want to say personally, it has been a real pleasure to work on a grant where the impact was so immediate and so local, where you felt you were making a difference in your state and in your community. As we dive into the grant specifics, let me leave you with just one statistic that highlights the work you all have done in improving your patients' health. When Ohio applied for this grant back in 2013 and 2014, Ohio was ranked 6th highest in the nation among the states for its rate of diabetes in the population as a whole. As we close out this grant, looking at CDC's current statistics, Ohio is now ranked 20th highest among the states in its rate of diabetes in the population. We have surpassed 5 of the other original 17 states working on this grant, and we have tied a 6th state in dropping our rate of diabetes. And that is with data that is 2 years old. As this most current data is submitted to the CDC, it'll be interesting to see how that figure improves. So with that, I'm going to turn it over to Kathy Rich to talk a little bit about the data collection. She was our data queen on this project, and talk about where the data came from.
Thanks, Kathy. It was fun to be the data queen, and I will move my crown now so that I can see the slides much easier. I did want to just talk a little bit about the grant basics on the ambulatory side. As Kathy mentioned, there were two portions to the grant that we were specifically involved in. The 1305 grant, which is the section in blue, was to actually gather data and then develop educational tools that would help address the issues of hypertension and diabetes, prediabetes, through training videos and webinars, and we'll talk about that later, but just wanted to kind of give you an overview. And then also Kathy talked about the 1422 grant, where we worked specifically with 6 counties, Athens, Lorain, Richland, Washington, Summit, and Montgomery, to provide technical assistance to them so that they would learn how to use their EHR more efficiently to help track these patients. So with that, I'm going to go ahead and turn it back to Kathy, and she's going to talk a little bit about the hospital discharge data.
Thanks, Kath. The other part of this grant, if you think about what CDC was trying to look at when they established this grant, on the one side, the controls that ambulatory providers have over the chronic conditions, but the other side is what impact is that having and how sick these patients are and how many of them end up in the hospital. So in order to get that second part of the data, the hospital discharge data, we were very fortunate in Ohio to have the Ohio Hospital Association as our primary source of data. And for those of you who work in the hospital, you're probably aware of this, but the OHA is the official data repository for hospital statistics in Ohio. So they were able to provide us with a report every year on all the hospitals in the state and how many of the patients who were discharged showed in their problem list that they had either diabetes or hypertension. And so that's the basis of a lot of our statistics on the inpatient side, and we'll take a deeper dive on that as we go through this presentation. The next area that we looked at in depth, and the Ohio Department of Health has spent a great deal of time supporting this in the state of Ohio, but it's a whole question of prediabetes. It's education and prevention. And I don't know about all of you, but I'll be perfectly honest. At the time that this grant started, I had no idea what prediabetes was. And the DPP program, which is the diabetes prevention program, was actually a new tool that had been introduced by the Center for Disease Control, CDC, and was then passed on to the states and private organizations to implement. The reason why CDC spent so much of their effort in this grant around the area of prediabetes being that stage between being absolutely healthy and before you are diagnosed with type 2 diabetes. So you're looking at those people who are at risk, but not full diabetics. And the reason why CDC felt this was an important population to work with is that over a third of the population nationally are pre-diabetic. And the feeling is if you can improve their health at this stage, you can then prevent diabetes in this population. And what a difference that would make in this country. Because what you're looking at is in the adult population, in the 65 and older group alone, 23 million adults have prediabetes, and it is not limited to one particular class of people, ethnic group of people. The information also, the other part of that was hypertension, with a simple premise that can we control people's blood pressure better? And if we can, is this going to improve their health? Because as you all are aware, hypertension is the underlying cause that affects many people as far as stroke and other chronic conditions that will basically disable them, has possibility of disabling them throughout the remainder of their life. In Ohio, when we started back in this grant, we had over it was like 56% of the population had hypertension of those people who were hospitalized. So with that, Kath, I'm turning back over to you.
All right, well, again, we're going to talk about the ambulatory data collection statistics. When we first started this grant and moving forward, we've always collected ambulatory data from providers in many settings, private practices, group practices, hospitals, as well as back in 2014, we were able to actually gather some data from 2 of the health collaboratives in the state. We specifically looked at data on NQF 18 and NQF 59, which were based on NQF 18 was the number of patients 18 to 85 who had a diagnosis of hypertension and whose blood pressure was adequately controlled during the measurement period. And then NQF 0059 or NQF 59 were the percent of patients aged 18 to 75 with diabetes who had a hemoglobin A1C over the 9.9% during the measurement period. And that was a reverse measure, so we wanted to keep their A1Cs lower than higher. We also gathered their unique patient counts by county. We wanted to know how many patients in each county were being looked at with these particular conditions. The data that was provided to us, once we received it and sent it on to ODH, it was always de-identified, so they just received statistics but did not know where it actually came from. But right now, I know Kathy did this as well, but I do want to thank everyone who is on today's call who did provide ambulatory data for us for this grant. I know sometimes with other things you had going, you'd get an email from us and you probably cringed, but it was all good cringing, and we do really appreciate it. So one of the things that I'd like to talk to you is just the collection statistics. And we were, during the grant period, the very first year, we only collected from a few counties. However, just through our recent data pool as of August 31st, we actually have collected ambulatory data from 77% of Ohio's counties, which is great. The more information we can provide, the better. 26% of those counties are actually located in the Appalachian Ohio region, and those are highlighted in the gray, just so you can kind of see that we collected from counties that have multiple different variances when we were looking at patients with these conditions. The importance on this screen is more to look at where we were in 2014 and 2015, which was our first initial, and where we ended up with our 2017 reporting data. We started with reporting from 3,002 providers. However, that included those 2 collaboratives that we spoke about. And in our most recent pool of data, we actually are recording information from almost 6,000 providers. The sites also increased back in 2014-15, 345 sites. And again, in the same period that we're just finishing up with, we're reporting from 648 sites. So you can see as the grant continued, we continued with all of your help to receive the information. Something that I think is very interesting on this slide is the last bubble in each of these is that the amount of nurse practitioners, other mid-levels like certified nurse midwives and PAs, how that has started to increase, that we've received data from more of those. So we're seeing how the mid-levels, in addition to MDs and DOs, are reporting data to us. So I think that's a very good point to look at as we're talking about all this. Another thing with the ambulatory data that we looked at, besides the number of providers and what counties did they come from, we also looked at the specialties and where were we pulling the data from. And this slide actually shows you that of the top 5 specialties that we reported to, it reflects 82% of all the providers that we gathered data from. So, family med, internal med, OBGYN, all the different specialties of surgery and pediatrics. So I think that gives you a good idea too of the data we're pulling, where those specialties came from. So with that, back to you, Kath.
Thanks, Kath. Okay, so drum roll, what does the data actually show? And this is where I have to be honest with you, when we started to sort through the data, I initially was thinking, was there a mistake? Did we draw something wrong? It couldn't possibly be, because OHA provides the exact same data to us every single year. But as the reality set in, that the data was so significantly improved, it really made us start looking at what the causes were. So for starters, the total discharges in the state during the grant period for adult population went up very slightly, 30,000 discharges, which was an increase of less than 3% during that 4-year period. However, the patients who were listed as diabetic in their discharge data decreased significantly by almost 30,000 patients during that time. But even more significant were the number of hypertensive patients, which went down by 112,000 patients, which was almost an 18% drop during that period of time for the patients that were hypertensive. Those represented as a percent of total discharges. We went from, in the state of Ohio, when the grant started, 43% of all the patients discharged from the hospital in 2014 were diabetic. When the grant ended, 39.5% were diabetic. During that same period of time, when we started, 56% of all the patients were hypertensive who were discharged from the hospital. When we ended the grant, that total was less than 45%. So huge, huge shift in the data. We saw that as we looked at the hospital data, the question was that supported by the ambulatory data? Did we show that the patients were being better managed on the ambulatory side? And the answer to that, first of all, is that we had significant data. Almost 6,000 providers we were working with or are working with. And the number of diabetic patients we tracked during that time were almost 500,000 diabetic patients. The number of hypertensive patients was over 1 million, is almost 1.2 million. And so the information was pretty significant in the amount that was tracked. What were the results? The results showed that on the diabetic side, in 2014, 2015, 43% of those patients had A1Cs out of control. So basically their diabetes was not controlled or was not being adequately reported. By the end of the grant, that figure had dropped to 35%, 34.6%, so that it was showing that the patients were both better controlled and that the practices were better at getting the patients in to get those A1Cs performed. On the hypertension side, this is a question of, was your blood pressure adequately controlled? When we started the grant, almost 64% of the patients who were seen were reported with adequate blood pressure control. This went up to almost 67% at the end of the grant. The diabetes prevention program, and kudos to the Department of Health, Liz Curry and her team, and the rest of the chronic condition people have spent an enormous amount of time getting diabetes prevention programs out around the state and supporting their development. And when we started this grant, we looked back and there were only 19 programs in the state of Ohio that were recognized by the CDC as diabetes prevention programs. Now, as the grant closes, that has almost tripled to 52 sites. And this is the DPP, for those of you who are not aware, is a healthy lifestyle program that supports people in their eating, in their exercise habits, and provides, underlying group support for that effort. How is that reflected around the state? Because I think that's an important thing, and thing that I think all of us around the state, you all, us here, the Department of Health, everyone is interested in knowing, is this improvement only in one area of the state? Are we seeing like intensive work that's producing good results, or are we generally improving? And the answer is we are generally improving. We were just thrilled to see in the statistics that every single region in the state, every single region had improvement in their A1C level, in their rate of discharges for diabetes and the rate of discharges for hypertension during that 4-year period. Specifically, here are the regions. I won't go through them all individually, but just note on the right-hand side the amount of change, or the decline in patients by each region with these chronic conditions in their problem list. And you can see that we had some really, really significant declines. And I think it's well worth noting we were over 10% in almost every single region in the decline of patients with hypertension, and had a 3 to 5% increase or decrease in the regions on the patients with diabetes. Why is that? We were like, what happened? Was this due to, I have to tell you, first day I was like thinking, what is it? What magic ball have we all pulled out? And we started with, was it, there's something in the coding? Was it ICD-9 to ICD-10, that produced a huge shift by the end of the grant? And the reality was that actually occurred earlier in the grant. That was 2 years before the close of the grant. And the reality is that the information that OHA pulled for us on hospital discharges already incorporated the ICD-10 coding. So we knew we had all the correct codings when this worked. So that didn't seem to be the answer. So the question was, what else was Ohio doing? What were you all as providers doing that would support such a significant shift in the health of the population? And the number one thing that we came up with was the alternative payment model movement within Ohio. And that included 3 major alternative payment models came in. 2 of them started during the grant period, and 1 really increased in the grant period. And those were Medicare Shared Savings Program, better known as MSSP, the CPC+ program, and the Ohio Medicaid CPC program. Those were the biggest alternative payment models that were adopted, although clearly we have other ones like the end-stage renal disease program that is being utilized by many urologists and providers who are supporting patients who have end-stage renal disease. But in looking at this, the question was, would this change to alternative payment programs reflect across the state? because it is not an even picture, and yet around the state there was improvement everywhere. So we went back in as much data as we had available to us publicly and tracked back to see where these alternative payment models showed up around the state. And so what we ended up with is for the CPC+ program, we had 68 of the 88 counties have providers who are participating in CPC+. As you, I'm sure, are aware that if you were in CPC+, you were also eligible to do the Ohio Medicaid CPC program. But beyond that, we had 3 additional counties that did not have CPC+ recognized in the program, but did have Medicaid CPC. And then 1 additional county where they were not participating in either of those 2 models, but were participating in Medicare shared savings. There are many groups that participated in 2 or 3 of these alternative payment models, and the significance of that you'll see in just a minute. For shared savings, at the beginning of the grant, there were 9 Medicare shared savings programs, which are the ACOs that could extend through, just a small group all the way up to hundreds of providers handling, 75,000 or more patients. As this grant closes, there are now 19 ACOs. The number of beneficiaries included in those ACOs, so you're looking at Medicare beneficiaries. When you're talking MSSP, that is strictly a Medicare population, and it started with about 200,000 in 2014, and we're up close to 500,000 now of beneficiaries. The results of providers who are working on shared savings is that their A1C totals have gone down, that they had about a quarter of their patients were out of control, whereas now at the end of 4 years, only 16% are out of control. Very, very good statistics. The same is true with hypertension. They have much better control over it. 65% of the patients were well controlled in 2014, and that's now up almost to 74%. So what impact do we see from CPC+ and the Ohio Medicaid CPC? The interesting thing is both of these programs started in 2017. So this grant really gives an excellent indication of the impact of those programs in the state. So we were, for those of you who are not aware of it, Ohio was head and shoulders above any other state in the nation with the number of sites that we had participating in CPC+. We have 562 sites, which represents 20% of all the CPC+ in the country. We have over 2,500 providers, which again is 20% of all the providers in the country, are in Ohio working under that model. And as you know, the CPC+ model is based upon a PCMH model. For the Ohio Medicaid CPC, it also started in 2017 with 67 organizations. And when I say organizations, that is not practice site, but is rather the umbrella organization that is contracted to participate. What is the difference, and how does this then reflect on the movement of data? CMS started the concept of chronic care management in 2015. It wasn't adopted very robustly the first year or two. It just was an unwieldy model. But that particular concept of chronic care management was incorporated into these alternative payment models. So CPC+ and Medicaid CPC both require the chronic care management program be part of the model, and that they have transitional care management of patients coming out of the hospital. The nice thing about these two programs is they include more than just the Medicare or Medicaid population and look instead to the overall patient population for that practice site. The shared savings model, as we mentioned before, is a Medicare-based program, but it does not require that you have chronic care management, but it assumes that you are using it. And I think that is well documented by the number of sites that were both shared savings sites and CliniSyncPLUS, that all of them had established these chronic care management programs. So we believe, and I think it is documented as you kind of pull all the data together, that it is the success of these alternative payment models that is representing better health amongst Ohioans. So with that, I'm going to turn it over to Scott to talk about some of the technical changes that we've seen over the past 4 years that have supported this move towards better management of these chronic conditions.
Our early work on this grant really focused on the EHR, through the Meaningful Use program, which is now called Promoting Interoperability. All of the hospitals in the state and the physicians in the state were incentivized to purchase and utilize their EHR system. So we focused our early work on ensuring that the EHRs were configured in a manner that would support the successful treatment and identification of patients with hypertension, prediabetes, and diabetes. Now, the work on an EHR can only go so far because the triggers, the CDS rules, the reports within those EHRs are based only on the information that's available within your EHR, which in most cases is not a complete picture of the patient. So then we focused our attention to the use of an HIE and an integration of the HIE from a technical standpoint with the EHR, but also integration into the workflows. This graphic here is a little bit older, but it really still rings true because studies have shown that HIEs do lead to healthier patients, more efficient care provided by the care teams, and more informed treatment decisions. And this is because the care team now has better access to the complete patient stories. EHRs, they now have data coming from payers, hospitals, physician groups, post-acute care, and even social service agencies. HIEs are also now layering on analytics tools, providing different views of the data and different solutions that make caring for your patients easier, more proactive, and again, providing more information about the patient. In the past, historically, data has been very hard to get for your patients, especially the sickest of the sick. Generally, those patients with multiple conditions and those that are highest risk see multiple care providers, sometimes more than 10. Those providers are generally spread across different organizations, and that means they're spread across different EHR systems, whether it's McKesson, Allscripts, Cerner, whatever. All of those EHRs had a piece of the patient's story, but didn't have the ability to provide the full patient picture, a consolidated picture of that patient. Well, now with the introduction of an HIE, the HIE can take those different data feeds, the different coding, the different information from multiple sources, and provide a unified, normalized view of that patient. We're going to shift our focus not from HIEs in general, but now to the CliniSync HIE here in Ohio. Throughout the life of the grant, we really have grown as an HIE. We are now up to 14 million patients that are uniquely identified within the HIE. There are only 11.7 million patients in Ohio. So this shows that we've, with our border states, we see a lot of patients who are transient that cross our Ohio borders. We have 156 hospitals that are participating. Most in Ohio. We do have a few from West Virginia and Kentucky that cross borders, and over 500 long-term care agencies. We believe that we have over 15,000 independent and hospital-employed physicians. And now, for us, the newest thing is health plan participation with the HIE. We have 7 health plans, 5 of which are managed Medicaid, that are participating in the HIE. When I say participating, that means, yes, they are consumers of data, but they are also required to contribute data back to the HIE. And we also, to show the bridge of the way an HIE can bridge the different vendors, we've connected successfully 60 EHR vendors to our HIE. Let's talk a little bit about the solutions, the tools that are available. The first thing we did was clinical results delivery. Delivering those A1C results, the lipid panels, all of the lab RAD, path micro results, and even transcribed documents from hospitals, from Quest, from LabCorp, out to those providers within the community. We also have the community health record. This is our longitudinal patient record that provides a single consolidated view of each patient who has been identified for which we have data within the HIE. This community health record can present as both a web solution or be directly integrated within your EHR. The solution that we've seen exponential growth here in this past year is we call it Notify. And it is just what you would think that Notify means. You will receive a notification of an event, whether it's an admission or discharge to an ED or an inpatient setting, and we can deliver those based on the provided patient panel. Contribute is kind of the core of an HIE. It's the data contribution, whether it's HL7, CCDA, now it does include some claims data that we're going to continually expand, but contribute data back to the HIE to provide even a more complete patient picture. And one of our solutions that we're going to talk a little bit more, actually Kathy's going to share about the work that she's done, is referrals. So now let's kind of step back and say, how does an HIE really support the care and treatment of a patient with diabetes, prediabetes, or hypertension? What the HIE does is it makes the patient central to the visit. Let's step back a few years. Prior to HIEs, prior to the advent of most EHRs, the data was, when a patient moved from one setting of care to another, the patient either brought a printed copy of their patient record or information was faxed back and forth. This took time, it created lags in care, it increased costs. Well, now as this patient moves from setting to setting, the data can follow the patient with little to no effort from the care team. So if a patient were to present to a primary care physician, a new patient, that primary care physician has a very complete picture of that patient's information available within the community health record. If that patient's identified with is thought to be pre-diabetic or maybe even diabetic, the referral out to a specialist now is just setting up the patient with that appointment. The specialist has access to that same data. They can see all that information, run more tests. The information applies back to the patient record, and the primary care provider can see that information as soon as it hits the HIE. They have access to it. And what this does is it changes the interaction between the patient and physician. No longer does the first part of the visit of a patient with their provider have to be, well, how's your A1C? Let's how are your tests? Let's get some blood work. Oh, I'm missing this part of your record. Now the conversation is, I can see all of your A1Cs. I can see them over time. I have access to your A1Cs, and I see that maybe your A1Cs are going up. Let's get you over to a diabetes prevention program, and they can talk about that, and then while talking about it, actually perform the referral electronically. They can see how the patient's weight is being managed through different settings of care. The same with the blood pressure. All of that information is available to the provider at the point of care in a more complete picture, so it really changes the interaction between patient and provider. We're going to dig a little bit more into referrals, and Kathy Rich is going to take us through that.
Thanks, Scott. I was sitting here listening to Scott, and we often talk about telling the patient's story or having the doctor be able to read that patient's story with all the information that is coming out of the HIE. And it made me think about the times when we used to just have books. Remember those things that were bound and they had pieces of paper? And if you were reading a book and a page was missing, what did you do? And so that's what kind of makes me think of referrals, because referrals are all done electronically. We can send and receive customized patient referrals in real time. So if that book is missing a page, you maybe had to go to a fax machine, or you'd have to go back to the library, or you didn't have that online tool to be able to see that. So as we're moving into electronic health records and we're talking about health information exchange, referrals become a very important part of this and an easy part for all of you in the offices, because it streamlines it. How much time do you spend making phone calls and faxing for referral information? It can help you coordinate referrals and ensures that you get a true follow-up of what's occurring, and it can be done through direct email or through use of the referral tool. So one of the projects that we've been working on has been up in Lorain County. We were working with the Lorain County Public Health Department, Lorain County Health and Dentistry, and the YMCA of Cleveland. And they had patients who were diabetic, needed to be referred to a diabetes prevention program, or as Kathy mentioned, a DPP. But how do you do that if you don't want to fax it? You've got the patient that's meeting someone at the Lorain County Health and Dentistry, and oh my gosh, they'd be perfect for the DPP, but how do we get that information to them? So we've been working with them to create a referral process where Lorain County Health and Dentistry would actually, have a patient that would be diagnosed using the CliniSync tool. They would go into CliniSync and they would be able to enter information about the patient, and then it would actually be automatically referred to the Y. And the Y was able to develop specific questions for Lorain County Health and Dentistry that would help them identify which program the patient should be in. So we actually developed different referral programs with specific questions for the DPP, the MDPP, which is the Medicare Diabetes Prevention Program, a blood pressure program, and then a general healthy lifestyle program as well. So all while these referrals are going on, CliniSync kind of sits in that background and just makes the magic happen, which, coming from someone who has a crown and a magic wand, that's pretty cool to me, is that is actually going on. But what happens during that referral process is that once Lorain County Health and Dentistry makes the referral to the YMC of Greater Cleveland, they're able to track that patient. So once the YMC schedules that person to go into a DPP, they can send that information back to Lorain County Health and Dentistry and let them know that. Or maybe they're a patient who went to a couple classes and then dropped out for whatever reason. That information can also be included in that referral. So the next time the patient goes to the Lorain County Health and Dentistry, that information is available to that provider. So as you can see, we do a lot of things in circles, but it's because that patient care and that story is a continuous loop of care that we want to try and handle. Another program that we've worked with pretty much from the beginning of CliniSync and the CliniSync HIE is the Medical Neighborhood Project here in Central Ohio. And we create this longitudinal patient record that pulls in data from all different areas. I mean, think of yourself as a patient. You may see a primary care, but you may also go for labs, you may have to go to the emergency room at some time, or maybe a parent is going into a nursing home. So all of these can be tied together, and through our medical neighborhood program, we were able to do that with the Healthcare Collaborative of Greater Columbus. And this next screen shows you the various organizations within the Healthcare Collaborative of Greater Columbus that are exchanging through our referral program. And if you just take a minute to look at some of these programs, you can see it's the Central Ohio Area Agency on Aging, the Charitable Pharmacy, the Free Clinic, you know, various different organizations that could all touch a patient in their life, and certainly those that maybe don't have access to care like you or I may have. So Scott, I'm gonna let you talk a little bit about the data mart.
Oh, great review of that referral tool and the work that's being done out there. You know, really it's the referral tool is all about making sure that the patient gets those services they need. Great solution, and there's been some great work done on it. Now I want to shift to what we call Data Mart, and this is a new service or a new solution from the HIE that I'm personally very excited about. But first, what I want to say about Data Mart is Data Mart is not an analytics tool, but it's a data service that you can use to feed into the analytics tools that you may have already at your organization. What Data Mart is it consolidates the record for your patient population. You provide us with a patient list, and we build a database of the patient information that's been shared with the HIE. This includes the clinical data from HL7 feeds, whether it's those transcribed documents, the labs, RAD, PATH, micro, also the CCD data that's been contributed. We're working real hard to also include the field pharmacy claims from payers and adjudicated claims from payers. So you can see that this picture of the patient is becoming more and more rich, more complete. We do have a full webinar or a full recording of an overview of the Data Mart that's available at the link that's included on this slide and included in the slides that you can download. Now, Data Mart is really comprised of two distinct data sets. The first we call our quality data set. This is available for your entire patient population. The way we identify that patient population, you give us a list. And this data set's primarily built around 28 HEDIS measures, which we're going to talk more about here in a little bit, but again, this is for all of your patients. We also have what we call the care coordination data set. Such a huge focus with all of the alternative payment models and with care in general on care coordination. The importance of knowing that entire patient story and managing care across settings. We make this data set available to your high risk or your intensive patients. The way we identify those intensive patients, you tell us who your intensive patients are. We pull that data together. We provide you with the data model, with the description of how this data is linked together, so that then again, your report writers, your analytics teams, your informatics team can make use of this data. The 28 measures that are available within the quality data set, you're going to see there's a huge focus on hypertension and diabetes. Those two leftmost columns, you're going to see under heart disease, we have controlling high blood pressure, hypertension improvement in blood pressure, and we even have statin therapy for patients with diabetes under heart disease. That whole diabetes column, that's one of the primary focuses of the grant. You've got the A1C, the eye care, the foot exam, the comprehensive blood pressure for those patients who have both high blood pressure and diabetes. And we selected these 28 measures through some work with we actually reached out to our members. We have a subgroup of our members that identified these measures as those measures that are of highest priorities. Our goal is to over time expand this. As the dust settles on Data Mart, we get more and more data sources, and we know we've got all the bugs worked out. This 28 measures is going to grow to 36, 42, and just keep expanding. So thinking about the HIE, we really have a population health tool with different solutions that provide support for different areas of focus. For your readmission and your network management, think about notifying, how you can tie in those notifications to identify those frequent flyers, those readmissions, and then dig into, now that you know a readmission occurred, dig into that prior to waiting for months and months for CMS to get that data to you. For your complex care coordination, you have the community health record. Again, you also have notify to know when the patient has an event. For your quality improvement, data mart. You have a complete full picture of your patient. And with the heavy focus on social determinants of health, that referral network can help, you know, with your patients that have food insecurity or have other needs outside of what we might think of as traditional primary care or traditional health care. Tie in the referral network for meeting those needs as well. Now I'm going to turn it back over to Kathy.
Okay, we're going to open it up for questions here in just a second, but before we do, I wanted to show you what's available for your own review after the webinar. We put in the statistics for every county in the state for diabetes and hypertension discharge data over the length of the grant, as I said, provided through the Ohio Hospital Association. So every county is listed. Then the next area is, this is the American Diabetes Association Diabetes Assessment Form that if you are not using, I would highly encourage you to use, and it helps you to establish who are at-risk patients for prediabetes that you can then spend a little bit more time on and get them hopefully referred to a DPP program. The other thing that you may want to look at if you don't have it already, I know a lot of systems moving to the 2015 edition CERT have built in these tools, but if not, here's an example of a DPP assessment form built into an EHR system. In this case, it's Meditech, but just to give you an idea of how easily it can be put in and then used by your providers. So with that, I'm going to turn it back over to, and also all these links are available to you for additional information. Scott, why don't, are you going to do the questions? Okay.
One of the things, the websites of interest I did want to just mention is through our series of improving Ohio's health for the grant work. On this website of interest, there are the various articles and webinars that we have put together for education. They're on all kinds of topics, and if you haven't participated or listened to them or read the articles, the links to them are here. I encourage you all to do that. We do have some time for questions. So the first one is, does the decrease in diabetes hospital discharges truly reflect a decrease in the incidence of diabetes? Or are primary care providers improving the outpatient treatment of patients to avoid hospital admissions?
Right, this is exactly what I think the grant was going to. What those discharge data statistics reflect is not that the prevalence in the population as a whole has declined, although apparently it has, but what it reflects is better management on the ambulatory side. Because what you're saying is that fewer of these patients, no matter what your baseline data is for hypertension and diabetics, fewer of those patients are ending up in the hospital. So it reflects better management. And for those of you who work in alternative payment models, you know this is something that CMS watches, and those are the ambulatory sensitive conditions. And how many of those are being admitted into the hospital. So it reflects that providers are doing a better job.
Yeah, the data, our data does show a 2.8% drop in out of control hypertension, but it's a concerted effort through the different payment models to better manage patients and keep them out of the hospital inpatient setting and the EDs as
Yeah,
well.
and that's why I think we show such strong ambulatory shift in data also, is that it does reflect that the patients are better controlled.
Great. This question is about the medical neighborhood, but I think one of you could probably respond, does it require the reading of lots of PDFs, or is it just all electronic?
Well, there's two things you can do with the referral tool. The referral tool, what we do is when we configure the tool, we configure the questions that receiving entity needs answered to provide care to your patient. So in the case of the diabetes prevention program, we set it up to say, okay, what was their BMI, what was their most recent A1C? We ask those questions so that way when that diabetes prevention program gets that information about the patient, they don't have to say, first, let's find out if this patient's eligible. They know based on the information they received that patient's eligible. They have all of their contact info. They can reach out to the patient. Yes, you can attach documents to a referral. You can attach a PDF, an Excel file, whatever you want, but we try to configure it so at least from the very beginning that receiving entity has the information they need to start caring for, pick up the pieces and care for that patient.
Yeah, and in conjunction with that, for a patient or a site that's a covered entity, they also get access to the community health record, so any additional information they need to provide services is provided.
And also from that community health record, there is a referrals tab where you can see every time the referral tool was used to move that patient around and what happened within that referral. So there's a lot of information in that community health record.
Here's a question, and it's specific to a certain area of the state. Some of the questions that are specific, we will reach out to you separately. However, this is one about the DPP. So is the DPP aimed at family practice and internal med physicians?
The DPP is not limited to one group. And the concept of when we've worked with organizations, OACHC and Family Practice and the Department of Health, it does not necessarily mean that the site itself has to start its own DPP program, although it can, and the tools are there to help you do that if that's what you want to do. But it's as much to teach you where the sites are and that you can refer when that patient is identified as being an at-risk candidate. But that referral can come from any provider. It does not have to be a primary care provider. It can represent a cardiologist. It can represent a GI doctor, anything that you want.
Yeah, our goal is that we make everyone aware that the DPPs exist. Here's the base information they need. That way, any care team member who touches that patient that recognizes that this patient now is pre-diabetic knows how to get that patient to one of these DPPs so that they don't progress to full-blown diabetes.
Perfect. The other part of that question is there a way to use the referral tool to keep patients out of the emergency room?
You can definitely use the referral tool. Anyone who's part of that network that helps to control that, whether it's a social services support group that goes to the issues of
Food insecurity.
Yeah, food insecurity or something like that, that would then push the patient to the ED, is definitely, you can say that it would support it. The other side of that, though, that I think you have to think of is one of the main reasons that we see practices use the notify functionality in the HIE is because they can track ED utilization. And that's an area that it was so hard for practices to get their arms around. And it can also track people coming out of the hospital so they don't end up back in the ED and are not readmitted statistics. And so there's a whole strategy around the management of patients moving in and out of both the hospital and the ED that are supported by these various tools.
That's all the questions we have, other than the ones that we will answer specifically to the person who asked.
Thank you all so much for your participation, and thanks to many, many, many of you for helping us with all the data. And with that, we'll see you soon out in the community. Take care.